evening. I'm Sandy Collier. Thank you for joining us. In part 2 of our series, Opioid Prevention Education, we have a full panel of experts to shed more light on the opioid crisis that is attacking our Black and Brown communities. Pharmacist Paul DeLissa will explain what are opioids and why are they so addictive. Dr. Blaine Cameron, pain management specialist, will share with us his thoughts on managing pain. Psychologist Dr. Gisette Smith will also talk about issues that could lead to addiction, and she'll talk about caring for yourself as you care for your patients. And we all know how important it is to be paid for the work that you do. And rounding out our series tonight is Dr. Ikana Nwamba, who will talk about billing and coding. What is the difference and why is it so important for both the patient and the medical professional? But first, an important message from our executive director and our board president.
Hello, my name is Laurel Dalton and I'm the Executive Director for the T. Leroy Jefferson Medical Society. I would like to thank you for participating in our education series today, along with our wonderful expert panelists as well as the Health Council of Southeast Florida. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for the Continuing Medical Education through the joint providership of Florida Area Health Education Center Network and T. Leroy Jefferson Medical Society. The Florida Area Health Education Center Network is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Florida Area Health Education Center Network designates this live activity for a maximum of 5 AMA PRA Category 1 credits, 1 credit per session. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Everglades Area Health Education Center, provider number 50-3066, approves this program for a maximum of 5 contact hours, 1 contact hour per session of continuing education credit through the Florida Board of Nursing, the Florida Board of Dentistry, the Florida Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and the Florida Council of Dietetics and Nutrition. Before we get started, I would like you to hear a little information about our medical society and our programs in the community. Most of these initiatives were made possible by grants and donations to our organization. We also have several gift cards that will be given out to attending pre-registrants by random number selection on the first live broadcast of this webinar. And at the end of the session, please scan the QR code or follow the link provided for the required assessment for your education credit. For those viewing live, the assessment will load immediately at the end of the session. Thank you again, and please enjoy this education session.
Hello, my name is Dr. Tiffany McCullough. I am a board-certified emergency medicine physician as well as a wellness physician. I am currently the board president for T. Leroy Jefferson Medical Society for the term 2020 through 2022. I'm honored to be here. T. Leroy Jefferson is made up of healthcare professionals dedicated to improving health and wellness, access to care, academic and career development, as well as being sure to create additional opportunities for the underserved community. With opioid deaths on the rise across all racial and ethnic groups, our society has elected to educate the provider community on opioid-related issues because truthfully, a project like this aligns perfectly with our mission. This is a 5-part series and it is made possible through a grant from the Health Council of Southeast Florida. According to the Centers for Disease Control, nearly 500,000 people, that's 500,000 people, died from overdoses involving any opioid. This includes prescription medication as well as illicit opioids. In recent years, nearly all racial and ethnic groups are affected, and everyone has really experienced a significant increase in opioid-involved related deaths. That includes synthetic opioids and manufactured opioids. With our overarching goal to save lives, we plan to educate medical providers to give them a comprehensive and holistic approach to teaching patients with acute and chronic pain. We aim to help providers. We are using a 5-pronged solution. These measures include improving their clinical decision making, helping to enhance their patient management strategies, helping physicians interpret new clinically relevant findings, analyze health policy, and having access to resources for review. I'd like to thank you, our viewers, for electing to take this opportunity for additional learning. We would also like to thank our team for making this possible. We ask that you would fill out the brief survey at the end of this opportunity so that we can know how to best serve you in the future. A special thanks to the Health Council of Southeast Florida for making this project possible. If you would like to know more information about T. Leroy Jefferson Medical Society, please visit us at our website, which is TLJMedicalsociety.org. Again, TLJMedicalsociety.org.
Hi, I'm Sandy Collier. Joining me is Paul DeLissa. He has 25 years of experience as a pharmacist. And Paul is going to talk to us about what are opioids, why are they so addictive, and why are they so prevalent in Black and Brown communities. Paul, thank you so much for joining us. Tell us a little bit about yourself.
Thank you. I'd like to thank also T. Leroy Jefferson Medical Society for giving me the opportunity to speak today, and also Ms. Sandy for being my host. I am a registered pharmacist in the state of Florida. I have a background in community setting. Also, I've done some work, and most of my formative teaching is in hospital. Working in a community setting, I have experienced this topic that we're talking about, opioids, and how they play a role in our society. And I see a lot of the negative and I see a lot of the positives that we can take away from this talk. Opioids are basically named or defined as opiates, opioids, narcotics, controlled substances. Their mechanism of action basically it attacks a receptor site, which is called a mu receptor site, and it has a very high affinity for that, which basically means it attaches very quickly and very solidly, causing this addictive property. And it causes analgesia, sedation, euphoria. It also can detrimentally cause some respiratory depression, constipation we see, and obviously physical dependence.
Why is it so, why is opioids so addictive?
I guess it has to do with the fact that that feeling that people get from it. That's basically what it boils down to, and that's called addiction. Um, it's just like anything else, smoking, drinking, all those are addicting type of. So, in reference to narcotics or opioids, they they act fully. They don't act partially where they can or cannot cause. They totally turn on this receptor, which is this mu receptor, and there are drugs that can turn it off and reverse it, which is nice to know.
So, Paul, as a pharmacist, when people come in without a prescription and they want a syringe, how do you handle that as a pharmacist?
Yes, fundamentally, what we do in the back of our mind is we try to determine the intended use. Without being biased, we just ask them a few questions, and then and one of those questions is, your the intent of disposal of the syringe, and then we obviously have to ask them because there's different types of syringes, so that will give us an inclination of what they're using it for. But the end result is we're creating a safe environment, because if we don't issue these syringes to these patients, they're going to end up using they're going to end up reusing syringes that were used maybe by someone else, and then we create a whole cascade of problems. So we look for intended use, and then we look for disposal techniques, and we offer that to them as well.
So, having a syringe available to anybody who can just purchase it, it's twofold. It serves good and it serves bad because it helps, and that's what I'm understanding.
Yes. So the intent is to give them a clean needle so that they can create a clean environment. The problem is that we are faced with, and what we see is that these syringes are just being tossed like a cigarette butt. They're just throwing it on the floor, and we're finding them, or we found them in the parking lots of our establishments and what have you. So what we try to do is also, we're issuing them the syringe, and then we're also trying to verify how they're disposing of the syringe. And we have disposal containers that are for purchase um, in most drugstores and most settings.
So, Paul, another question I would have for you. In terms of a person coming in and getting a syringe, and they are really, really, they haven't had a fix, is that, I guess that's what people say. They haven't had a fix in a while, and they use a syringe. Tell me about people ODing in the bathroom, and from a pharmacist's point of view, what do you guys have to do to try to save that person's life?
Yeah. So when the initial transaction or interaction occurs and we see that this person is acting inappropriately, we would ask them kindly to come back because we don't feel comfortable issuing it to them right now, because we can identify that maybe they're under the influence. So as a result, they're going to make poor judgments. They're going to want to do something right away. Maybe they can have another caregiver or another party come on their behalf. But we try to address their condition and just tell them, this is not appropriate right now, how you're behaving, and they know how to resolve that. hmm So we don't let it get to that point, and then we identify that they're with someone, and then we can have a conversation with them just to put things in a safe setting.
Paul, what do you think can be done to combat the problem with opioids?
Well, for one, there's got to be better education. There's got to be better outreach programs for these individuals, because they are suffering from a mental and a physical perspective. But then you have the argument is they have to want this help. So I think what we're doing now is obviously it is a band-aid, but until these people, want the help, then we're going to be able to provide it. And I'm sure these things exist out there.
From the perspective of a pharmacist, in your opinion, can we get on top of this?
We can be part of the solution. I don't think we're the complete solution. This requires a group effort. This has been going on for a number of years. Morphine was discovered in, I think, 1803. I was reading, so this is not something new. And people want to escape. They want to feel better, and so they use these means to do so. We've had an opioid issue 10 plus years ago where it got out of control. And it was a doctor issue. It was also a pharmacy issue where they were writing and we were dispensing. The state had to come in and put some governments on things. And now pharmacists are required to do 2 hours of continuing education because the pendulum went from filling all these prescriptions and prescribing all these prescriptions to a point where we stopped filling them. So then people that needed the medications suffered. So we had to come to a common ground, and education was a part of that solution. And so, like I said, pharmacists are now required before they renew their license every 2 years to do a 2 hours of continuing education on controlled substance prescribing. And that gives us some perspectives on what to look out for, what we call red flags, and then we can go back and educate the prescribers and what have you.
So, Paul, let's talk a little bit about what are some of the other dangerous, addictive medicines. You just talked about morphine, opioids. Tell us, let's talk about that.
So what we see in our community setting, these are legal drugs. We see medications or opioids such as fentanyl, hydromorphone, morphine, as I mentioned, oxycodone is a hot item, hydrocodone. These items are really, really hot, and they have legitimate, purpose for being prescribed. And it's our job as pharmacists we're under this clause called corresponding responsibility. So when we are presented with a prescription, we have to determine if this prescription is legit or legitimate, I should say. So we have to ask questions both to the patient and to the doctor. A lot of times that becomes offensive. We have different things that we look for. We look for the quality of paper that the prescription was put on. In the state of Florida, it has to be on a registered prescription paper. And then we look at the date that it was written. Sometimes we're presented with a prescription that's dated a few months ago. So we question that. Okay, now you're presenting this to us. Then we look at the name on the prescription. The female, sometimes she uses her name, uses her last name conveniently. So we want to make sure that it matches. And then if it doesn't, we have to obviously call to verify that. And then we look at the directions and quantity. And then there's some other features that we have to look for to make sure that the prescription wasn't altered. As safeguards.
So, let's just say you have a doctor or a medical professional that's writing prescriptions and you know that it is not legitimate. How, as a pharmacist, how is that handled?
That has to be reported. If we definitively know that a doctor is writing prescriptions for a financial benefit and not for the care of a patient, then we legally have to report that to our local authorities, and they do an investigation and what have you. Yeah. So that's part of where pharmacists are considered safeguards in the medical field. In the perspective of therapies, and the therapy obviously relates to the prescription. So a lot of times, we're catching things that are maybe inappropriate or just don't make sense. And obviously we don't know, like, what's really going on. That's something that I would love to see more transparent when prescriptions are being written. I know we have to control HIPAA, which is patient confidentiality when it comes to their medical features. But we as pharmacists need to have some idea or inclination as to what's going on. And so they've put some things into play on a state level. When a prescription is written for pain medication, it has to be put on there for acute pain or non-acute pain. So that puts us in a position where we can now measure, is this going to be a short-term therapy or long-term therapy? And what's helpful, and this is for like doctors that are writing prescriptions, to mention or to document maybe a medical code that discusses what's being treated, or just something limited, maybe like for headaches or for back pain, so that we can kind of summarize the treatment plan and what's going on.
Wonderful. So, Paul, we have a lot of medical professionals that are listening to us. So, to summarize for them, what would your advice be to them listening?
Okay, so primarily my message would be to understand when we're receiving the prescription, we have a corresponding responsibility to kind of summarize the treatment that's being presented to us. And again, without infringing on the patient's infringing on HIPAA, and how it relates to the patient and the doctor, we just need a few things to help us. So diagnosis codes are we embrace diagnosis codes. Anything that you can add to the prescription in regards to, as I mentioned, as needed for headaches, as needed for back pain, those are helpful features that will help us kind of summarize the treatment of what's going on.
Paul, thank you so much for joining us. You gave us a lot of valuable information. I'm Sandy Collier. We'll see you next time.
Thank you.
I'm Sandy Collier. In this part of our series, we'll cover chronic pain management as well as provider-patient coping. We'll also talk about the effects of opioid addiction on the brain, strategies to support patients undergoing opioid treatment, and ways in which physicians can practice self-care whilst dealing with patients who are dealing with an addiction. And what can Black healthcare professionals provide specifically for people of color? Coming up after the break, Dr. Blaine Cameron, a pain management specialist, will join me via video conference. And we're back with Dr. Blaine Cameron, a pain management specialist via video conference. Dr. Cameron, thank you so much for being here. Let's start with you. Tell us a little bit about yourself and your practice.
Thank you for having me. Yes, my name is Dr. Blaine Cameron, and I'm board certified in anesthesiology and in pain management. I currently practice in South Florida. We have 3 offices, one in Loxahatchee, Wellington area, one in the Boynton area, and one in Hollywood. And we've been practicing in the area for approximately 10 years.
Wow, what an accomplishment. Dr. Cameron, tell us, let's delve right into this topic. What are the best strategies for patients who are undergoing opioid withdrawals?
Okay, very good question. So there are different levels of withdrawal. If a patient is undergoing mild withdrawal, they want to make sure that they're in a calm, quiet place, because one of the symptoms or part of the symptomology of the withdrawal is going to be anxiety. So the patient needs to be in a calm, quiet environment, well supported. They want to make sure that they stay well hydrated. That said, oftentimes withdrawal can escalate to the point where it becomes moderate to moderately severe, in which case the patient would need to seek medical attention. And there are various treatments that can be offered. While some patients will do well with meditation and moderate exercise, such as walking, we do find that patients who do excessive or strenuous physical activity actually have a worse experience and worsen their withdrawal. And as I said again, you may require medical treatment as far as medications to treat both the symptomology and medication to treat the withdrawal itself. Yeah. And there are several medications currently in use, which include things such as buprenorphine, methadone, clonidine, and there's a new medication called lofexidine, which is a non-narcotic medication that treats opioid withdrawal.
So you kind of almost answered the next question with the first question, but is there anything else that you can add in terms of how can a healthcare professional, be it a physician or a nurse, best support a patient who is going through withdrawal?
So the healthcare professionals should attempt to assess the level of severity of the withdrawal, and we do have tools that we use to do that. There are different questionnaires. There's the COWS, the SOWS, the CINA, the OOWS. Some are subjective, some are objective, as far as the clinical signs and symptoms of the withdrawal. If the patient is in mild withdrawal, oftentimes they can be treated with, being well hydrated, 2 to 3 liters a day, vitamin supplements, vitamin C, vitamin B, quiet, calm environment, meditation, moderate exercise at best, and that would be things such as walking. No, they should not be forced to do physical exercise. Oftentimes, when a patient is in withdrawal, they can be confused, and that's not necessarily the best time to start psychological treatment and counseling. However, if they're disruptive and they're having behavioral problems, behavioral treatment can be started. If the patient is assessed to be in more moderate, severe, or moderately to severe or severe withdrawals, oftentimes they need to be referred to a healthcare professional who can prescribe medications such as buprenorphine. And not every physician can prescribe that, and as such, that physician can be identified on the appropriate. There are websites that list all the medical providers who are certified to prescribe buprenorphine and methadone, etc.
So let's talk a little bit about the Black healthcare professional, and what do you think the Black healthcare professional can specifically offer to patients of color?
Okay. So I think that the best thing that the Black healthcare professional can be is to be a patient advocate. And they can do that by doing things such as using patient centered language, particularly when documenting on the patient. Because what we want to do is we want to separate the individual from the diagnosis. We don't want to have the patient be put in a situation where they come under undue bias, as this can affect, and as we know for a fact, this affects healthcare. And what I mean by patient centered language is there's more than one way to state what is transpiring. For example, if a patient is given a medication and the patient does not take a medication, if you write and document on the chart the patient refused the medication, that sets up a dynamic, a bias for anyone who's going to come across that patient's chart and who's going to encounter that patient. And the patient is better served with patient-centered language, such as the patient did not take the medication, or the patient declined to take the medication, and it might be helpful to document why the patient said, they had an allergy to a similar medication and they didn't like starting several new medications, or they wanted to try non-medical treatment first, or other non-medical options, things of that nature. That is very helpful for the patient's care going forward. It helps the patient in the future to establish rapport and to have their diagnosis treated and to not encounter undue bias, and again, to separate the individual from the diagnosis.
So, this next question, I'm sure you probably get a lot of, because I'm curious myself. How can physicians and patients both take care of their mental health to stem the effects of dealing with the patient or a family member who's dealing with an opioid addiction?
Yes, this is a very complex issue because oftentimes we see in practice that the patient is not the only one affected by their diagnosis. It often affects their family members, their close friends, and it affects it in several socio and economic ways. Patients oftentimes can have problems with finances, their jobs, and oftentimes, if the entire family is affected, it may be needed that the entire family have family therapy. Certainly, the patient at some point would benefit from therapy, whether that be psychological therapy, counseling, group therapy, or behavioral therapy. It can be very stressful. Oftentimes, the patients are suffering from anxiety. You know, there are non-medical treatments, there are medical treatments, there's counseling, there's therapy, there's psychological treatments. And then as far as the lay people and as far as the layman's treatments, things that they can initiate without the healthcare uh, providers' assistance, are things such as meditation. If the person is religious, certainly that is a very good uh, support system. There are a lot of resources available in several different religious institutions, whether they be whatever religion the patient ascribes to. And then, like I said, moderate exercise, things such as yoga, tai chi, obviously exercises that are commensurate with the patient's level of functioning, because particularly with opioid addiction and opioid medication and withdrawal, oftentimes there's an underlying problem that needs to be treated as well. Oftentimes these patients actually have pain, a medical pain problem that has not been addressed, and that should be addressed, because to have a patient in withdrawal and still having pain, it just adds another level of complexity that is often very difficult to cope with for both the patient and any family members, friends, or any support system that is around them. So that is another aspect that oftentimes I've seen overlooked. And it is my experience that until the underlying problem of pain is treated, it is extremely difficult to treat withdrawal or any opioid use at all.
Dr. Cameron, thank you so much for joining us. A lot of food for thought there. We'll see you next time.
Thank you for having me.
I'm Sandy Collier, and joining me is psychologist Dr. Gisette Smith. Dr. Smith, thank you so much for being here. Let's start with you telling us a little bit about yourself and your practice.
Thanks for having me. My practice is Authentic Self Psychotherapeutic Services, located in West Palm Beach, Florida. So I've been practicing there for the past 3 years, but before that, I've been practicing throughout Broward County, working with chronic mental illness, trauma, and also addiction, which co-occurs with a lot of mental health conditions.
Dr. Smith, we have so much to talk about today. What are the top things that both providers and patients should know about coping with opioid addiction and recovery?
I think first, providers and patients need to really understand that there's a biological basis to addiction. So it has nothing to do with the person being a bad person or having like a weak or low moral character at all. It has a huge biological component which drives addiction. A second thing that they need to know is there's different parts to addiction. So a lot of times people think of dependence and tolerance as addiction when it's three separate things, really. So tolerance is when a person has to have an increased amount of the substance in order to receive the same effect. Then we have dependence, where if a person stops taking the opioid, they might start having withdrawal symptoms. And lastly, there's addiction. So that's something that's progressive. So with addiction, we see people that have intense cravings and really compulsive behaviors in order to obtain the substance that they're seeking, despite any negative consequences that they might be experiencing at that time.
So, doctor, that brings us to a very important question then. What are the effects of opioid addiction on the brain?
So opioid addiction on the brain is very complex. However, to put it simply, so opioids attach to the opioid receptors. So we have pain pathways and then we have pleasure pathways. So if it attaches to a pain pathway, then it reduces and eliminates pain. If it attaches to a pleasure pathway, it reduces neurotransmitter called dopamine, which then leads to the effect of pleasure. Dopamine in a healthy brain is released when we do healthy behaviors such as eating, exercising, and even sex. But in an unhealthy brain, it starts to produce when the opioid is taken.
So, Dr. Smith, dealing with addiction is stressful on all the parties involved, the doctor, the patient, and the patient's family. How do you cope with that?
So there's different things for each person to do, really. So for example, patients really, it's really important and very crucial for patients to start psychotherapy. When a person goes through the detox phase, when the drug is leaving their system, that is not enough for treatment. So that's just the first phase, the detox phase. After the detox phase, we want to address the factors that may have led to the addiction in the first place. So life stressors, different circumstances that the person might have been experiencing that initially led them to seek that drug to begin with. As far as family members go, it's really important also for family members to receive some support. So families can receive support in terms of other family members. There's a group called Al-Anon. They're located throughout the country in different cities. It's family members getting together to receive support from each other and education and resources. It's also important for family members to engage in family therapy themselves. There may sometimes be dynamics underlying the individual's addiction, so and dynamics also that make it difficult for the person to recover.
So, doctor, in terms of the doctor, him or herself, how do you cope?
I think it's really important for doctors and physicians to have a clear understanding of these two terms. So transference and countertransference. So transference is when a client or patient takes unconscious material, something that happened in their life at a different point, and they kind of transfer it onto the physician, right? So they're transferring something that has nothing to do with the physician onto the physician. And this can sometimes lead to what we call countertransference, where the physician might be acting in a way that's responding to the way the client is treating them. So it's important to have a good idea of what that might look like. So once you have that clear idea, it's easier to take a step back and look at the situation as it unfolds instead of responding to it. That's going to take a lot of consultation. So consultation with colleagues, being able to set clear boundaries with the patient and the family members even, because it's important to remember that addiction is leading to a compulsive behavior. So the individual is doing things that they might not do like if they weren't on the substance, so they might be more forceful, they might become aggressive. So there's different things that the physician has to be aware of so that they can take a step back and not become too overly involved with the patient.
Wonderful. And whilst we're talking about that, we have a lot of medical professionals that are joining us. And as we close, what is your advice to them?
So my advice to them, like my advice to a lot of people would be, is self-care. So making sure that you place your self-care on the forefront of anything that you're doing, because we can't help anybody unless we're helping ourselves first, right? So some of the recommendations that I have are engaging in therapy themselves, taking vacations if they can, taking time away from the practice, being very mindful of the moments that they have, being appreciative, making gratitude lists. So doing these things to kind of remind them to stay grounded in what they have going on in their life and appreciative and not becoming too overly involved, because it can become very dramatic with addiction.
Thank you so much, Dr. Smith. I think I'm going to take some of your advice. Thanks for joining us.
Thank you for having me.
We'll see you next time. I'm Sandy Collier, and in this session, we talk about billing and coding. And joining me is Dr. Ikenna Wamba. Dr. Wamba, thank you so much for being here. Tell us a little bit about yourself and your company.
Thank you for having me. My name is Dr. Ikenna Wamba. Formerly trained as an internal medicine doctor, uh, and also have a passion for the business side of medicine. So last year, I joined a company called Gentem Health, and we apply analytics and machine learning to the process of collecting from insurance companies so that private practices can get paid more and get paid faster.
So talking about billing and coding, what's the difference between billing and coding?
Yeah, that's a great question. It's definitely something we're not taught in medical school. However, billing relates to submission of claims to insurance companies. And there's a whole process involved with that, including following up with the claims and managing issues that might arise if the claim is not accepted. Coding relates to transcription or translation of the medical documentation into numbers that the insurance company uses to reimburse providers for their services. So typically, when you see a patient, you're going to write up information about that encounter. You're going to involve someone who's an expert in coding to support the work that you did. And then you're going to have someone who submits the claim to the insurance company so that you can get paid for that work.
So, in terms of coding, doctor, what codes can be applied for addiction coverage?
So when you are coding for addiction services, it really depends on the payer that you're using. Each payer has different codes that are necessary to get reimbursed for services. So with your commercial payers, they go by CPT codes, specifically 99408 and 99409. For your Medicare, they go by G codes. And the G codes you're going to be looking at are G0396 and 0397. And for your Medicaid payers, you're looking at the H codes. And those codes are HH0035 and HH0036.
Why are those codes so important, doctor?
You know, it's the codes are important because without knowledge of these codes, then your practice won't get paid what it deserves for the work it's doing anyway. So it's very important to stay on top of codes. And what a lot of private practices are seeing is the challenge that arises when you have to reduce your overhead, meaning letting some people go and still staying on top of these codes as they emerge. So that's kind of where we help at Gentem, is to support these private practices with knowledge about codes as they emerge, changes to codes, and building that into their workflow so that they can be more efficient.
So, Dr. Wamba, how can we make sure that doctors are coding properly to ensure correct payment?
Yeah, so coding is very important and is especially important in the context of complete and holistic care. So where there's an opportunity to educate providers about the new codes that are emerging, or if there are activities that can enhance your staff's knowledge about these codes, really makes a difference on the patient side, because the patient is essentially getting all of the services that they're entitled to, and the practice is being fully paid for those services. It's very important to do that to maintain the sustainability of healthcare delivery. That's why at Gentem Health, we do the very best job of working side by side with clinicians and with the team to ensure that the codes are being used effectively and that the claims are being submitted timely as well. We bring transparency to that whole process with the dashboard that gives providers unparalleled insight into their financial operations. So you're staying on top of not only the work you're doing, but also how much you're getting paid for that work. And it's being accurately reflected in your information systems.
So, Dr. Wamba, is there anything else you would like to discuss to inform physicians concerning billing and coding for this opioid epidemic?
So, what I would say with respect to billing and coding is that things are only going to continue to get more challenging as new regulations emerge, new policies emerge. This is going to require more work of the private practice to stay up to date. Essentially, we expect there to be an increase in not only the claims that have been submitted for telemedicine, but also for the audits on those claims as well. And this trend is likely gonna be going on for the next 12 to 16 months at least, given not only the opioid pandemic, but also the COVID-19 pandemic as well has spurred new regulations to be thinking about.
Thank you so much, Dr. Wamba, for sharing your insights with us. I'm Sandy Collier. We'll see you again next time. Thank you to all of our doctors, and we have quite a few questions for each of you right now. So let's start with Dr. Gisette Smith. Dr. Smith, what factors lead to a diagnosis of opioid addiction, substance use disorder?
Okay. Hi, how are you?
I'm doing well, thank you.
I'm so happy to be here. So, you were asking about the factors that lead to a diagnosis of an opioid addiction. I guess to start, I would say that within the field of psychiatry and psychology, so we use what's called the Diagnostic and Statistical Manual for Mental Disorders. It's in short the DSM. It's a guide that we use to help in diagnosing. It's actually sometimes referred to as psychiatry's Bible, just because it's referenced so much, and it has all the different psychiatric conditions in there. People shouldn't be using, just shouldn't diagnose without having the specific criteria, and I'll go over those as well. So within that DSM now, we don't use the term addiction. So we use the term substance use disorder. So you mentioned substance use disorder. In this case, we're speaking of opioids, so it would be considered an opioid use disorder. So in terms of the opioid use disorder, there's 11 different criteria, and we go through the different criteria to see what an individual meets. So for example, there's different severity levels. So if an individual meets 2 to 3 symptoms, they might be considered mild. 4 to 5 symptoms are considered moderate, and then 6 symptoms or more are considered to be a severe substance use disorder. Some of the symptoms that we look at are if the drugs are taken in larger amounts, if there's an unsuccessful attempts to cut down. So if a person wants to stop using and they've tried to, but they just can't seem to cut down, that's another indication that they might be having a substance use disorder. And also just one more to give an example is just if they're spending a great deal of their time looking for that drug or recovering from the effects of that drug.
So that brings me to the next question. So after a substance use disorder is diagnosed, what does treatment look like for that individual?
Okay, so it depends on the severity of the disorder. So looking at how long they've been using, how much, like what the different amounts are that they've been using, it's going to determine what level of care they need. So for an opioid use disorder, traditionally, a medically supervised detox will be needed. And the length of the detox will be, I guess, dependent on like the factors that I talked about before, their length of time using. That could last anywhere from 7 to 14 days. But again, it's individualized based on the person and what they're going through. Once they are through that physical withdrawal and that section, if they're still needing inpatient treatment, they will receive psychotherapy, like in the form of individual psychotherapy or group psychotherapy on an inpatient basis. They'll learn stuff such as the importance of changing people, places, and things. A lot of times in substance use, primarily cognitive behavioral therapy is used. That just teaches people how to identify the role that their beliefs actually play in their behaviors, and actually just learning like what their core beliefs might be. And the core belief is their basic beliefs about ourselves, like their selves in the world, and then how those beliefs are influenced, how it influences their feelings and behaviors.
Thank you so much, Dr. Smith. Dr. Nwamba, this question is for you. Which payers are participating in reimbursement for alcohol and substance abuse screening? Dr. Nwamba?
Yeah, can you hear me?
Yes, I
can you hear me?
You. Yes, sir.
Okay,
yes.
Great. Yeah, so reimbursement for screening and brief intervention is available through commercial insurance, Medicare, and Medicaid.
And what documentation is required to bill for alcohol and substance abuse screening?
Great question. So screening, brief intervention, and referral for treatment requires a structured assessment and a brief intervention. So as an example, let's say you see a patient and you do some of their social history. You would want to conduct a kind of a questionnaire, and you would want to document that. So you can use the alcohol use disorders identification test, which is a 10-point questionnaire, or a drug abuse screening test, which is a 28-point questionnaire, but you would include that documentation in your notes. And as far as brief intervention, what you can do with that patient is to discuss different substance abuse recovery services, or refer that individual patient to a substance abuse specialist and document that you did that as well.
So the next question for you would be, for all the medical professionals that are here, how can providing these services impact their bottom line?
Yeah, it's a great question. So these services are, they're paid based on how much time you spend delivering them, which can range from 15 minutes to 30 minutes or more. So if you spend 30 minutes or more rendering these services, you can increase your, assuming that your visit is $100, you can increase your revenue up to 60%. So that'd be $60. And if it were only conducted for 15 minutes, it'd be half of that. And that's pretty standard across the payers. Especially the commercial and Medicare payers.
Well, thank you so much, Dr. Nwamba. Dr. Blaine Cameron, this next question is for you. Are there any procedures available for the treatment of arthritis?
Available. Yes, there are several interventional treatments available for arthritis. Unfortunately, we cannot cure arthritis, but what we do is essentially we can ablate the nerves that innervate the problematic joints. We cannot do this in all joints, but we can do it in joints that have the sensory portion of the nerve separate from the motor portion of the nerve. And the joints, these include joints such as the knee joint, the back, the neck, the hip, and even the shoulder. This can alleviate a lot of the arthritic pain and thus can let the patient have the potential to wean off of some of their opioid medications, or at the very least, cease any opioid escalations that may be necessary because of the patient having continued arthritic pain and developing opioid tolerance.
Thank you, Dr. Cameron. Let me apologize to everybody. We're having a little bit of audio problems with Dr. Cameron. I'm not sure if that's on this end, Dr. Cameron. But let me move on to the next question, and this is going to be for Paul DeLista. So, Paul, what are the alternatives to providing syringes to those addicted to opioids? And also, how do you find a balance between a patient's safety and reducing their addiction?
That's a good question. Good evening, and thank you for having me. First and foremost, we just want to have the interaction that we want to have with the patient. We just want to make sure that they're aware that that these syringes need to be disposed of correctly. And we would just have a back and forth conversation to verify how they're disposing of it. And if their answers are not correct, then we can obviously educate them on that and provide the proper equipment to dispose of it. And I think to answer the second part of the question, I think just educating and having that open communication with them, letting them know that we care about them as a person and that we're here to help them.
And the next question for you would be, do you think pharmacists are given enough resources and support to help combat the opioid epidemic?
Oh, that's a great question. I think it's an ongoing battle, and it's an ongoing process that we're still learning. I think it comes with experience, and having these particular venues like that we're in now helps us to better understand the process and what's going on in the patient's mind. And obviously we know fundamentally that they're making poor decisions. So all we can do is offer them whatever services that we can to and reiterate to them that we care.
Wonderful. Dr. Smith, we got another question here for you. And can you talk a little bit about cross addiction and the implications in long-term treatment?
Okay, absolutely. So the idea of cross addiction is basically when an individual that has an addiction to it could be, for example, a substance, and then their addiction, like when they stop using that substance, it transfers to something else. It could be another substance. It could be a sex addiction. It can be a gambling addiction. But the idea is that they have this compulsive behavior that then transfers to something else. I think that is why psychotherapy and kind of learning yourself and learning your patterns and behaviors and why the addiction started is really important, because that can reduce the chances that will happen. Because as you're learning the reasons why you might have picked up and started using an opioid to begin with, I guess assuming that you weren't using for a chronic pain situation, there's some people that pick up and use recreationally, and then they become tolerant and dependent, and then they have the addictive behaviors. So learning why you picked up in the first place will help reduce the chances that you develop an addiction in a different area. And I will say this, so the whole premise behind Alcoholics Anonymous and NA groups as well is complete abstinence for that reason. So knowing that, like, just because you might have an alcohol use disorder and you're completely abstinent from alcohol doesn't mean that it's safe for you to then start experimenting with cocaine, because you're at an increased risk for developing, a cocaine use disorder.
Well, thank you very much, all of you doctors, for joining us tonight, and our participants. Coming up on our third session on Monday, August 24th, We will chat with Dr. Akiva Dum, who specializes in substance use disorder, and we'll also talk to Tanya Young-Williams from Pivot Treatment Center. And just as a reminder, before you sign off tonight, please remember to fill out your form to ensure that you get your credit for this segment. Thanks again to all of you for joining us. I am Sandy Collier. Take care of yourself and take care of each other.